Hi, my name is Ana Feijão. I'm an echocardiographist working in Angola, and I'm here to give you some tips to apply in your echocardiography exams. I apologize for my English, which is not the best, but I will try to speak slowly. After releasing some videos with the basic concept of performing the transthoracic echo, I received feedback with questions related to the practical part. This is how this project came about, approaching the step-by-step of an echocardiographic study in order to answer the various questions that arose. Now, I work in a cardiology department at a private medical center with a Mindray DC-70 device, and I'm ready to give you tips and guidelines to optimize your echocardiographic study and get excellent diagnosis from it. I'm going to do an exam from start to finish, so you can understand what I evaluate and how do I do the measurements. This way, we can address all the parameters measured and calculated within a normal exam. For the video not to be too long, I will divide it by incidences. Let's start by talking about the Paraesternal Long Axis view. I start by laying the patient in the left dorsal decubitus position so that the heart is closer to the place where I will place the probe. The right arm should be extended along the body, not like this image, and the left arm should be flexed upwards to open up the intercostal spaces more. If the patient is unable to lie on his side, I perform the exam in the position the patient is in, seated or lying on their back. It is possible that the image is less good, but I will do my best. Next, I put gel on the probe and, before that, I'm just going to show you some important terms for your exam to flow. It is usually necessary to make small movements on the probe to get a good image. The hearts are all different, the patient's morphotype too, and this means that we have to make small adjustments to get the most perfect cuts possible. Angling the probe. Reaching more towards the sternum, rotating it millimeters, rotating it a lot or a little, are all movements that are gained over time. And the expression having hand. We say that in Portuguese. I don't know if you say it like this in English. And the worse the image, for example, smokers, obese patients, or patients with lung pathologies, more skills we need. But beyond the experience, it is important to know how to adjust the technical commands in the best way. Having a sense of what the command does and how to adjust it is very important. Depth, sector width, focus, overall gain, and time gain compensation are essential commands to get a good image. We must start with enough deep depth in order to visualize the extracardiac structures as well. Evaluate pleural effusion, for example, if existent, and the organization of the pericardial effusion. The gains must be adjusted in order to see the thinnest cardiac structures such as the valvulet and the endocardium as best as possible. But it must not be exaggerated. The cavities must be anechogenic, which means without echoes in their interior. We can also adjust the time gain compensation to compensate for a particular region or remove the gains. So let's begin the exam. I start with the Paraesternal Long Axis view, which is located here. The mark or index of the probe, here, must point to the patient's right shoulder as seen in this arrow. like this. And the probe must be in the third or fourth intercostal space. And we have an image. We have left ventricle here, right ventricle here, aorta, aortic valve, left atrium, mitral valve, interventricular septum, posterior wall, also known as lateral inferior wall, left ventricular outflow tract, the zone just before the aortic cusps, and descending aorta. First, you should decrease the depth in order to leave 1 centimeter of extra cardiac space at the posterior level. Okay, here. In this view, I don't change the width of the sector because the heart is exposed longitudinally, and if we reduce the sector too much, we will cut the left ventricle and aorta. The focus must be positioned at the level of the posterior wall. This focus is a little bit higher, but if there is any area with less definition, I change the focus there, because focus improves the lateral resolution of the image. We have the focus represented by this triangle. So it's time to begin the evaluation of the cardiac morphology. The first thing we should notice is the relationship between the cavities. The left ventricle must be the most exuberant cavity. The aorta and the left atrium must be approximately the same size, and the right ventricle must appear discretely at an anterior level. Okay? Left ventricle is bigger than all the cavities, and aorta approximately the same size, the left atrium. The first thing I look at is left ventricle contractility. The walls must approach homogeneously and must thicken, that is, become thicker. And we know that it has a good systolic function when the difference in diameter of the cavity in diastole, that is, when the walls are farther apart, and in systole, when the walls approach to each other, is significant. Later, we will talk about some methods of quantifying the systolic function, but I would like to make it clear that the most important quantifying methods are based on this relationship between the size in diastole related to the size in systole. I think it's important to make a small aside because it is essential to have an idea of the phases of the cardiac cycle and what the term frame means. It is important to understand that telediastole corresponds to the first frame after mitral valve closure, and telesystole corresponds to the first frame after aortic valve closure, as you see in the pictures. Therefore, in order to evaluate the frame following the closing of the mitral valve, I have to freeze the image and rotate it with the mouse until the mitral valve is closed. When rotating a little further forward, the first image after closing the mitral valve is the right frame to measure diastole. As you can see, in this image, the mitral valve is still open. If you lightly press the mouse forward, the mitral valve will be closed as shown here. We then know that we are in telediastole. The same goes for knowing in which frame we can find the telesystole. Here, the aortic valve is open, and in the next frame is already closed. Okay? This image corresponds to telesystole. Remember what a frame is? I talk about this subject in the video about the physics fundamentals and the controls of the device. Frame is an image, and a video is made up of thousands of images. The more images per second, the more definition a movie has. I can also use the information of one lead EKG, but you need to know that the electrical component is not 100% synchronous with the structural component. This explanation is pertinent because in order to access the systolic function of the ventricles, we are going to carry out some measurements explained later, and for that we need to know how to define exactly telediastole and telesystole. Okay, returning to the explanation of paraesternal long axis view, after qualitatively evaluating the systolic function by the contractility of the ventricular walls, I evaluate their echogenicity linked to the Gray scale. Myocardial echogenicity is the variation of this scale within the myocardium. And I evaluate thickness of the walls. Of course, it is a subjective evaluation. Later, I will explain how to evaluate quantitatively. The right ventricle must be smaller than the left ventricle, and its wall must be thin. The wall of the right ventricle. A muscular band, the moderator band, can be seen at the intraventricular right cavity, which is a normal structure with no pathological significance. In this video, it is not very perceptible, but in several patients we can see an echogenic band with transverse orientation inside the cavity. Here or here, like this, which can often be confused with the interventricular septum. Right ventricular contractility should be subjectively evaluated here as well, checking whether the cavity in systole has a significant difference compared to the ventricular cavity in diastole, and whether the free wall thickens normally and along its entire length. The aortic valve is the most important valve in the heart, as it is the one that connects it to the entire body. This valve must have thin cusps. It is normal for older patients to have slightly thickened cusps, but it should be an homogeneous thickening without bright spots. Normally, these hyperechogenic spots are organized calcium. When this is the presentation, it is a sign that the cusps are calcified. It is also important to assess the opening of the aortic valve. The cusps should move away from each other, leaving almost the same diameter as the left ventricle outflow tract. In this example, we can see the right coronary cusp. Here is the more anterior cusp, and the non-coronary cusp, here, more posteriorly. They are not very noticeable, which is a good sign, as it means that there is no thickening of the structures. The mitral valve, which has a very complex valve apparatus, should also have thin leaflets. In the same order of ideas, if the test is performed on an elderly patient, it is normal to find some thickening or fibrosis, but it should not have calcium spots, and it should have a good opening. The leaflets must open well, and when they close, they must close before the mitral valve plane. This zone below the leaflets, an imaginary line connecting the 2 points of the mitral annulus. In this example, we can see the leaflets with good mobility. Here, the anterior leaflet, and a smaller leaflet here, the posterior leaflet. I also evaluate the morphology of the subvalvular mitral apparatus, such as the chordae tendineae and the papillary muscles. Not very well seen here, but it should appear here. When very thin, they may not be visible. We must evaluate aorta arteries, which is the artery that continues the left ventricle to the rest of the body. We start by evaluating its morphology. The root must have approximately the same diameter as the left atrium, here. It must taper slightly in the area of the sinotubular junction. Here you see the diameter is lower than this root diameter. And it must have a linear continuity to the ascending aorta. The loss of definition of the sinotubular junction can be a degenerative sign resulting from some pathology or advanced age. You must write this information in the report. The interior of the lumen should always be evaluated and images searched inside, images that should not be present. Finally, I look at the pericardium. I see the line that defines it, okay, this line here surrounding the heart, which is this more echogenic line around the heart. It's brighter. If it's thin, if there's an echogenic zone separating it from the myocardium, which, if it exists only in systole, it's normal, like in this example. And if there is an echogenic zone at the level of the right ventricle free wall, here, it could be pericardial fat and not pericardial effusion. We must try to understand if there is pericardium between this area and the myocardium. This example is a case where we can see at an anterior level a thin line of effusion. Here is the effusion, here is pericardial fat. After evaluating the bidimensional paraesternal long axis view, I already have a lot of information that I can use to direct the study. Then I evaluate with color Doppler to understand the dynamics of blood flow inside the cavities and in the passage through the valves. I will start by opening up the color sector to assess it at a general level. It gets a little messy on the eyes with less practice, but with experience it gets easier. To improve the interpretation of color Doppler, I usually increase aliasing speed to a little higher value to not have color mosaic pattern in normal streams. As you can see, in this example, the velocity is 58.7 centimeters per second, okay, here. In thin patients, where I can use higher frequencies, sometimes I can evaluate color Doppler at higher speeds, greatly improving flow definition. I also slightly lower overall 2D gains, and so I can better understand the dynamics of the flow, increasing aliasing speed and lower overall 2D gains. It is important to see if there are turbulent flows, if there are significant or mild regurgitations. For example, in this case, we can see in the area below the aortic cusps, here, this turbulent flow that corresponds to a slight aortic regurgitation. And the same can be seen at the atrium surface of the mitral leaflets. Discrete flow that corresponds to mild mitral regurgitation. Then I will evaluate the three main points with the smallest color sector, which facilitates the interpretation by improving the quality of the color Doppler. Where are the 3 points? Aortic valve and left ventricular outflow tract, interventricular septum, and mitral valve. Okay, let's go. I start with the aortic valve. I define the color sector to include the valve, and so that we can see the flow a little before the valve and the flow a little after the valve. I assess whether there is any turbulent flow supra or subvalvular, as we can see in this example, both of them, both with central jets. As you can see in this example on the right, we have a turbulent flow in the left ventricular outflow tract, here, which corresponds to mild aortic regurgitation. It is a central jet flow which occupies a small diameter of the outflow tract and does not reach far into the ventricle cavity. These characteristics point to mild regurgitation. Placing the M mode over the color sector at the level of the left ventricle's outflow tract can be important to temporarily characterize the events and to assess any abnormal flow. This is another patient. Here you see a blue jet, turbulent blue, because it goes away from the probe. And here is an anterior regurgitation jet that appears with another color. To assess the mitral valve flow with color Doppler, I set the color Doppler sector again, place the same sector on the mitral valve, and also assess whether there are turbulent flows, stenosis, or regurgitations. As you can see, we have a central jet, a blue one here, representing mitral regurgitation. And finally, I place the color sector on top of the interventricular septum to assess a possible interventricular communication. Finally, the Paraesternal Long Axis incidence is evaluated by bidimensional and with color. I will now evaluate some particular situations. It may be important to evaluate the mitral valve in more detail. And for that, we can use the zoom command that allows to enlarge the structures that are inside the sector. In these examples, the mitral valve has an atypical morphology. In A, we can see that the leaflets are thickened, and when the anterior valve leaflet is at its maximum extension, outlines doming. That is, it is not fully extended. This aspect is characteristic of rheumatic valvulopathy. See the doming here. Here, in the example B, I present you with an example of restricted opening of the mitral valve, also rheumatic, where we can see in detail the points of calcification of the leaflets. Here you see more echogenic, these points in the leaflets. The poor opening of the leaflets, very different from this, suggestive of stenosis, and the doming appearance of the anterior leaflet. One of the most important aspects of the echo is the variety of diagnoses that this exam can give us, especially the information about the cardiac function, systolic and diastolic. And this type of information is based on quantifications. I will then begin to address some quantifications that are carried out in the echo exam. This incidence is perfect for assessing the size of the left ventricle walls and cavity, the right ventricular cavity, and the diameter of the aorta and left atrium, as these measurements start from points that are transverse to the ultrasounds, making their definition better. I start by evaluating the size of the aorta diameter. The diameter of the aorta is important because it is what will tell us if the aorta is dilated or not. I can measure the diameter by bidimensional, as we can see in image A, or by M mode, as we see in the B example. When we measure by bidimensional, we must align the aorta well in order to have a good visualization of its entire initial portion. Aortic root, sinus of Valsalva, sinotubular junction, and the remaining continuity of the aorta, ascending aorta. It is important to measure several diameters: aortic root, sinotubular junction, ascending aorta. Therefore, from time to time, it may be necessary to move up an intercostal space to obtain a better cut, or even to bring the transducer a little further to the sternum to see a larger portion of the aorta. When I studied echo, they advised me to make these measurements with M mode, as it increased the definition of cardiac structures. I confess that I prefer to measure by bidimensional because there is no responsibility to align the cursor perpendicularly with the aorta, which is sometimes quite difficult. We don't always have a good opening of the aortic root when we have a good alignment with the left ventricle. So sometimes we have to make small movements on the probe, tilts, to align and open the aorta and left atrium well. It may even be necessary to align the aorta well to measure the root and then align it better to measure the sinotubular junction or ascending aorta, and do another tilt or angulation to measure the transverse diameter of the left atrium well. In Mindray ultrasound, measurements are made via the measure menu. Here, the aorta submenu must be chosen and the caliper will appear when we give the OK to measure. The aortic root and the remaining portions of the aorta should be measured using the leading edge to leading edge technique. What does this mean? It means to make the measurement we must place the caliper on the most anterior echo of the anterior wall of the aorta. Here, okay, this is the wall and this is the most anterior echo of the anterior wall of the aorta. And to finish measuring the diameter, we must place the second caliper on the most anterior portion of the posterior wall of the aorta. Okay. Then I measure the transverse diameter of the left atrium. Mindray ultrasound measuring left atrium by bidimensional, we need to go to Measure menu and choose the Dimensions submenu, which will have several options. Choose the left atrium option, LA. If we are measuring via M mode, when activating the Measure menu, we must choose the AOLA submenu. Aorta left atrium submenu. The measurement should be taken perpendicular to the long axis of the aortic roots and measured at sinus level using the leading edge to leading edge technique. If this measurement is done using M mode, we have better temporal resolution, but using bidimensional, we have a better perception of the right plane to measure. Do not forget that it is a uniplanar measurement, it is not very representative of the real size of the left atrium, especially if it is a dilated one. In order to know if the left ventricle is dilated or not, if it has preserved systolic function, or if it is hypertrophied or not, we must carry out some very important measurements. And they are measurement in telediastole of right ventricle, this one, not shown in the board, the interventricular septum, left ventricular cavity, and posterior wall in telediastole, and in telesystole measurement of left ventricular cavity here. The measurement of the left ventricle and the walls can be done by left ventricle M mode or by two-dimensional. Okay, here, two-dimensional, here, here, and here, M out. Personally, I prefer to measure in two-dimensional, as I said, despite the better resolution of the M mode, since one of the requirements for a good measurement is that it be done perpendicularly to the longitudinal axis of the left ventricle, and this is not always possible with M mode. First, we have to keep in mind some requirements when measuring the walls and the left ventricular cavity. The measurements must be taken just below the level of tip of the mitral valve leaflets. B shows the wrong way to measure because the cursor cuts the ventricle at the level of the middle segments and not close to the tips of the mitral valve. Here are the tips, here is the cursor. It should be like this. The measurements must be made perpendicular. For this reason, like I said, I personally prefer to take measurements in two-dimensional, as it allows us to align the measurement perpendicularly to the longitudinal axis of the left ventricle. In this example, the longitudinal axis of the left ventricle is pointing superiorly, which will interfere with the perpendicularity of the cursor. In this case, it is preferable to use an anatomical cursor, a tool available in the Mindray ultrasound model that I use, or to measure it in two-dimensional. To measure the cavity, the caliper must be placed on the top of the endocardium, the interface between the myocardium and the cavity. See this line here between the myocardium and the cavity. When measuring the thickness of the interventricular septum, we must be careful not to include the moderator band of the right ventricle. See the moderator band here, shown here. The interventricular septum ends here. When measuring the thickness of the posterior wall, also known as infralateral wall, we must be careful not to include the papillary muscle, chordae tendineae, and pericardium. Here you see, this is the pericardium, this is the posterior wall, and this is chordae tendineae, not included in the measurement of the wall. In order to confirm whether a certain echo is part of the wall or if it belongs to another structure that should not be included in the measurement, we must confirm it in two-dimensional in order to better understand the continuity of the structures and the echoes that we have to include or not in the measurement. We must pay attention to the values. Realize if there is any measurement that is altered or that does not go against what we are subjectively analyzing. And if we have this attention, we can always repeat it for a better orientation of the study. So, to do the measurements, I freeze the frame when I have a good image. Then I choose the cycle. If it is in 2 dimension, I choose a frame in telediastole. If I measure in M mode, I place the cursor at the beginning of the QRS on the EKG, aligned with the morphological telediastole. I call the measure menu. The software automatically defines whether it is by M mode or by 2-dimensional, as it depends on what is activated at the moment. I start by calculating the dimension of the right ventricle in telediastole. This should be done from the anterior wall of the right ventricle, not including the wall, to the interventricular septum. An important note is that this 2-dimensional measurement must be taken from the free wall of the right ventricle to the septo-interventricular aorta junction, in a line perpendicular to the longitudinal line of the left ventricle. I'm going to show you. This is the septo-interventricular aortic junction. Here, here, okay, and here. I continue measuring the interventricular septum, the left ventricular cavity, and the posterior wall. Normally, at the end of diastole, the software calls the systole cursor automatically. If not, we can choose it from the menu and call the cursor manually. If measuring in M mode, the diastole and systole are in the same frame. In measuring in bidimensional, we need to choose the telesystole frame, choosing with the help of the mouse the corresponding frame. Last measurement on these incidents, left ventricle cavity in systole, in the same heart cycle, very important, in which we calculate diastolic measurements, orienting the cursor at the end of the T wave, if we are orientating the cursor by the EKG. The measurements show up in a table like the one here, here, or here, where IVSD represents the interventricular septum in diastole, LVIDD represents the left ventricle internal dimensional in diastole, and LVPWD represents left ventricle posterior wall in diastole. EDV, estimated diastolic volume, is the volume of the left ventricle estimated by the software based on the measured diameter. IVS, S, and LVPWS represent wall measurements in systole. I don't normally measure the wall in systole. What I do is subjectively assess whether the walls thicken or not. LVIDS represent the measurement of the internal dimension of the left ventricle in systole, and ESV refers to the estimated systolic volume. The software also automatically calculates the systolic volume, SV, the shortening fraction in percentage, here has Fs, and makes an estimated calculation of the ejection fraction, here identified as EF. Like I said before, we must pay attention to values, because if we are present with a measurement outside the normally limit range, we have to measure more often. We have to measure with some tilts to see if the probe's orientation and finally to see if it really is a measurement that implies a different direction of the study. At first, it is difficult to memorize all the reference ranges. I advise you to have the tables easily accessible so you can see and compare your measurements with the limit range defined by the guidelines. An important note, do not forget that this left ventricle measurement is a measurement based on only two segments, basal septal and lateral inferior or posterior basal. And to assess its size, we must always assess its volume. I'll explain further. Another assessment that can be made is the mobility of the mitral valve by M mode. By placing the cursor over the leaflets, we can perceive the mobility and thickness of both leaflets with the good sensitivity that M mode offers us. We can see the M-shaped anterior leaflet here, and the W-shaped posterior leaflet here. See a W. In these two examples, we can see the M-mode presentation of a stenosed mitral valve, okay, B and C. A, it's a normal valve. Another characteristic of a stenotic valve, when the leaflets lose their mobility, they lose the M and W shape characteristic of the normal mitral valve. As we can see here, you can see here and here, you don't have the M shape and W shape. The anterior leaflet is rectified and the posterior leaflet appears pulled back by the anterior leaflet. In C, we have an example of a mitral valve with a severe stenosis, okay, here, with almost no perceptible opening, with much more marked thickening than in the two previous examples. Okay, the left ventricle outflow tract is the left ventricle area that precedes the aortic valve, and for a few millimeters in length, it has a tubular shape. See the shape here? In this image, we have a zoom of the left ventricle outflow tract, and we can see here the aortic root, okay, here, aortic valve, and in this area below the aortic cusps, we have the left ventricular outflow tract. It is important to talk about this region because left ventricular outflow tract diameter is a crucial measurement for calculating aortic valve area and for calculating stroke volume. Stroke volume appears as the basis of various information, such as the calculation of systemic cardiac output, an important parameter in the quantification of the systolic function, or to understand the relationship between systemic output and pulmonary output, the famous KPKS calculated on congenital shunts, or to quantify regurgitation by relating the total output passing through the valve and the actual cardiac output. The diameter of the left ventricular outflow tract must be measured using the zoom option. We should choose a frame in mid-systole and use the inner edge to inner edge measurement methods approximately 3 to 10 centimeters below the aortic valve. The limits are the compact myocardium of the basal septum and the mitral anterior leaflet, as we can see in the image. Here I finish the video on the Paraesternal Long Axis view. Wait for the next one about Paraesternal Short Axis view. I hope you enjoy it. If you have any questions, please post them in the comments or email me. Thank you.